This is a procedure aimed at obtaining larger adhesive area of retained tooth tissues and the prosthetic reconstruction. The advantage of lowering the gingival margin with the laser is a bloodless postoperative area, which allows for direct reconstruction of the tooth during the same visit. Additionally, laser reduction of gingiva is a permanent effect and thus prevents the gingiva from secondary postoperative gingival overgrowth. Before beginning the procedure, we inform the patient about the procedures involved during the treatment and give postoperative recommendations. Vivident Optradam screens make it easier to work. They enable greater access to the treatment area and protect the lips and cheeks from accidental mechanical damage. Additionally, they reduce the tension of the patient's mandibular muscles, which in turn makes treatment more comfortable. The procedure is performed in local infiltration anesthesia below the gingival line, both from the cheek side as well as from the tongue side. Owing to the fact that laser procedures cause little pain, the amount of the anesthetic can be limited to 0.2 to 0.5 milliliters. Before applying the diode laser, putting special protective glasses on is required, as per the manufacturer's recommendations. The dental root can be quickly secured from accidental damage from the laser beam with photocured cement. We have applied the Thermex SEM Compomer. We perform the procedure with circular movements along the gingival line of the root, gradually moving deeper, making sure not to damage the sulcular epithelium or the periodontal ligament of the extruded tooth. We move to the tip of the laser, applying minimal contact with tissues but without putting pressure. We can remove the remains of vaporized tissue with a curette. The glass ionomer cap is removed easily by using a probe or a curette as a lever, or, in case of difficulty, using ultrasound. After performing several corrections, the root is prepared for attaching a rubber dam to it for additional protection. In such difficult conditions, even the gingival clamp of the rubber dam can be displaced. For additional protection and insulation of treatment area, we once again apply Thermex SEM. It is easy and quick to apply, and its white color significantly distinguishes it from the materials that we will use for further tooth reconstruction, thus preventing the auxiliary material and final material from joining. We make sure that we apply the cement further than the final preparation margin. We now restore the tooth thus prepared using one or several fiberglass inserts and composite cement reinforced with glass fiber. Also, in the event of large cavity, high wear-resistant cements are recommended, such as with the addition of zirconium. The system presented here is Harvard Zircon Core plus photochemo-cured dual bond. Zircon Core can be applied both for fixing inserts as well as for tooth crown restoration. Its homogeneous structure and suitable density considerably ease application, and its high degree of hardness, comparable with the hardness of dentin, provides for considerable control during the final preparation before the final molding of the crown. The preparation reaches below the margin of reconstruction of destroyed tissues, creating a ferrule effect, and this is of crucial significance to proper attachment and functioning of the restoration. After making the preparation and before taking an impression for a temporary crown, we perform laser coagulation in order to stop bleeding or the exudate from the gingival pocket, interdental gingiva. While molding a temporary crown out of composite material, we should secure the tooth stump as well as the neighboring teeth with glycerin or another isolating substance to prevent them from sticking together. We've made the crown quickly and easily by applying the direct technique. While the material is setting, we can already check the intermaxillary relationship. This will additionally facilitate our subsequent work while adjusting the height of the temporary filling. While building the temporary crown, we must pay special attention to fitting in the shoulder area and to its shape close to the gingiva, so that during the healing process, the gingival papillae and interdental spaces are shaped correctly. Using temporary cement, we mount the temporary crown onto the surface previously protected with glycerin, while we facilitate its subsequent dismantling. We adjust it in occlusion. We can also slightly exclude this reconstructed foundation from occlusion, thus relieving the masticating surface of the crown. After the procedure is completed, a biostimulation procedure can be applied to speed up the healing of the tissues that have been reduced by the laser.